Hello, everybody, and welcome to the ALS United Mid-Atlantic Goals podcast. My name is Tony Heil, and I'm here with ALS United Mid-Atlantic. And if you've listened to our past episodes, you know that we've spoken with people with a wide variety of perspectives when it comes to ALS. That includes people living with ALS today, people who've lost a family member or loved one to ALS, people who are currently a caregiver, many members of our care team, including nurses and social workers, as well as people beyond our ALS community network, including people who are working on things like Huntington's disease and Parkinson's and other issues that impact our community as well. We've also spoken with some great researchers here in the ALS world, including Dr. Daniela Zarnescu from Penn State Health Hershey Medical Center, and others who are doing great research across the country to lead us to new treatments and cures for ALS and to improve quality care. Today I'm going to be talking with Dr. Zachary Simmons and Dr. Kathleen Twomey from Penn State Health Hershey Medical Center. Dr. Simmons has been leading that center at Penn State Health Hershey Medical Center for 30 years now and has made his clinic really a focal point in the country, one of the top leading centers across the United States. It's a destination for other leaders in the ALS sphere and in the research sphere, where they know that this is a real hallmark, not of only of Pennsylvania, but of ALS anywhere, to learn and to improve ALS care. And Dr. Twomey is going to talk to us about some of the advances she's going to be helping with in terms of pulmonology and improving care for people with ALS in Pennsylvania. So Dr. Simmons and Dr. Twomey, thank you for being here today. I'm encouraged to talk about your work.
Thanks so
Thank you.
much. Yep, thanks for that really kind introduction, Tony. I'm really thrilled to be here today and to be able to talk about this because this is a very exciting initiative for our ALS clinic. The motivation for this came from the fact that our patients that we have cared for years almost always end up needing and receiving some type of support for their breathing, because unfortunately respiratory insufficiency and eventually loss of breathing are the main causes of death in ALS. So most patients at one point or another do require some type of intervention in order to sustain their breathing as well as possible. We've been doing this in a way that's been fairly standard for most ALS centers for a number of years, which is that when people's breathing levels fall below a certain level, usually what we call 50% predicted for their forced vital capacity, we then use a mask or some other type of what we'll call non-invasive ventilation in order to support their breathing. And we know that non-invasive ventilation prolongs lifespan and improves quality of life in people with ALS. So it really has become standard of care. But interestingly enough, the way that that's administered varies greatly from center to center, and we've done it without direct assistance from a pulmonologist for a number of years, yet it's becoming increasingly clear that we can provide better care if we coordinate that with someone who is truly an expert in doing that. And that was my reason for connecting with Dr. Twomey and asking her if she would join us in providing best possible level of care for our people with ALS. So what we do now is when people are referred to us and we see them and monitor them in clinic, when their breathing capacity falls below a certain level, we will automatically ask Dr. Twomey to see the patient, and we have also taken other patients that we've been monitoring and caring for a while and asked her to assume their respiratory care. So I'll let her talk a bit about herself and about her role and how we're going to be working together.
Thanks. So I've been working at Penn State now for a couple of years as well. Have not been involved directly with the ALS Center before now, but I had just finished my pulmonary critical care fellowship. And when I was taking on a job at Penn State, they said, they mentioned to me Dr. Simmons' request, and I was thrilled to be able to help out. My training involves a lot of ventilator support in the ICU all the time. But we also have a lot of patients in our pulmonary training who use ventilators at home for various conditions. And ALS is a really unique patient population where we can really work on optimized settings because, like Dr. Simmons said, comfort is really one of the key things here. We're trying to very nicely extend life by supporting your breathing, because honestly, it's one of the most important things you need on a day-to-day basis. So if I can make somebody more comfortable with their mask and wear as much as they need to, some patients only need it several hours a day, some people do need it around the clock, then I know that I've made somebody's day just a little bit better.
That's wonderful. And Dr. Toomey, you said you've been there for a couple years. What was your background that brought you to Penn State Health Medical Center? Like, was it a goal to be there? Was it just how you ended up there? How did this become your destination?
Sure. I have now been at Penn State twice, not in synchrony. I did my internal medicine residency here, and then I worked as a hospitalist for several years out at Ohio State. And by the match, because that's how we get our fellowship spots, wound up coming back to Penn State. But it was nice to be able to come back here because it's a great hospital. We have so many different patient populations that we're able to help out with. And I was looking to stay in the area because I'm from New Jersey, and it worked out that this opportunity came up that I could have a niche area that I could work in the clinic setting and then continue to do my intensive care that I love as well.
That's wonderful. It's really great that Hershey Medical Center is able to attract such great talent. We spoke with Dr. Grogan earlier this year, Dr. Geronimo, and as I said, Dr. Zarnescu, and all of them came from other parts of the country because they were really excited about the work going on at Hershey Medical Center and the forward-thinking mentality there, especially for ALS care. And that's because, Dr. Simmons, you've really built this up for 3 decades now. So I'm going to get into more. Maybe we talk another podcast about this, but just briefly, Dr. Simmons, how long has the clinic been there at Hershey Medical Center? And just generally, how many people do you think with ALS you may encounter at your clinic throughout the year?
Sure, I'd be happy to briefly talk about that. So I came here in 1992, and we started really a multidisciplinary clinic in 1994. And initially, multidisciplinary was really bidisciplinary. It was myself and a nurse who the ALS United provided for us at that time, Sue Walsh, and then gradually grew into the whole team that we have here now. We have a team consisting of myself. There are now 4 nurses that work with us, and as well as a variety of therapists and a psychologist and a social worker. And we see about 100 new people with ALS per year. We follow about 250 people with ALS overall.
So I'm asking that also because what a multidisciplinary center is for you has changed a lot since the mid 1990s. Like you said, it was bidisciplinary care back then, and obviously it's grown. So this is the latest evolution in that care. How has that care evolved from the mid 1990s at Penn State Health Hershey Medical Center?
Yeah, so interestingly enough, at the time that I started working in ALS, it was really the very dawn of providing, other than what I'll just call very basic supportive palliative care to our patients. It wasn't that the care wasn't good, but it was that our ability and our knowledge were much more limited at that time than they are now. So that even Dr. Twomey may be able to provide more details about this, but even such things as we consider quite basic now as non-invasive ventilatory support were just not all that commonly given at that time, and other things that we take for granted now, like feeding tubes if people need them, a lot of the power equipment that we have were really exceptional rather than common at that time. But because the way of caring for people's breathing has evolved so much during that time, it's gone from us simply prescribing these devices to really trying to do it much more thoughtfully and to ask, how can we really provide best pulmonary care rather than simply some type of pulmonary care? And so we've relied a lot on our respiratory therapists, who are excellent, but quite frankly, a standardized prescription from a neurologist, even when supported by very good respiratory therapists, is much different than having a pulmonologist being able to coordinate that sort of care with you. And many pulmonologists don't have the type of training or expertise in outpatient care that we often look for in an ALS physician. That of necessity, much of their training is in the intensive care unit, but fortunately, Dr. Twomey has interest and expertise in both. Katie, if you'd like to comment on that a bit.
Yeah, to go back to what you were saying about the multidisciplinary care, in my short time now working with the ALS patients too, I can say this world's been amazing. I can see how this evolution has come, and I'm grateful that I am working in it in 2025. Like the technology for all these devices is just so profound. And I also get to take advantage of the other multidisciplinary aspect of this too. I'm on the phone almost every day with one of the respiratory therapy companies who handles, I think, the majority of our patients here at Penn State. And it's a really great relationship because I can take all of my inpatient knowledge and adapt it into something that the patients can use out in the home. So I can look at their information online to see how well they're using their machines on a nightly basis or 24-hour basis. Just being able to send someone, hey, these are my settings that I need somebody to be updated to because I can tell this is what they need based on various issues that are being relayed back to me. It's really a good, amazing time to be involved in this. And I think the patients are overall very happy when they wind up coming in for an appointment and walking away with a plan of this is what we can do for tonight and make things better.
It's interesting that you mentioned about how you fit in with a multidisciplinary approach because I imagine that you then can talk with other people and see how another discipline at the clinic benefits the work of a pulmonologist. So assistive technology or even mental health, different things that can come up where you can provide some sort of context on your end of here's how breathing can impact this or how that can impact breathing, and it gives you a fuller picture of how you can provide care.
Yes. And at the end of the day, I want people to be happy and comfortable at home and not in the hospital. So I feel like that is my driving force for what I'm doing day to day. Most of the time we are talking about how to use the ventilator best, but there's other machines that we're also using, such as our cough assist device, to really make sure that they can get all the phlegm out of their, chest that could be accumulating because they're getting gradually weaker over time. There are some other breathing treatments that I can prescribe to people too, and it's all with the intention of helping people have a calm day and not have to think about their breathing so much.
And thank you. And the other thing that I'd want to add when we asked Dr. Twomey if she would be gracious enough to join our group was that we do have a small group of individuals with ALS who decide that they want to have their life prolonged as long as possible and who opt to have a tracheostomy, meaning a tube in their throat, and to be placed on a mechanical ventilator around the clock. And although that's not the majority of our patients, it is a difficult decision for them to make. And then once underway, a series of difficult choices and situations that they're in that they really do need expert help to work with. So now when those people express that might be an interest of theirs, we can ask Dr. Twomey to talk to them and help walk them through the process, even if it involves just starting at the very beginning to make a decision about whether this is what they would like or not.
Absolutely. I've done that now several times with the patients. And, we're not making decisions often on that first conversation, but it's really great to start understanding what somebody knows about this already to, get to their more maybe direct questions, because a lot of people do their own homework. The internet is a wonderful thing, but then I can give my perspective too as somebody who works with tracheostomies for various patient populations on a day-to-day basis. And it's been really nice we did have one patient who received a tracheostomy recently. I was able to check on him in the hospital and then help start the transition for him going back home and work with that home health company again. So it's really nice to be able to touch on someone's care in all the different directions and not just kind of like, it's not just a linear process. This is a constant reevaluation of how I can help somebody and address the changes that happen.
I know that ALS care is so unique, including when you go to the ER and you see someone that's not an ALS specialist. So we have had communication with patients about what kind of information you share with another doctor if you have to go to the emergency room or something else happens. Do you educate patients and caregivers then about what to alert other doctors about, especially in an emergency situation, when it comes to breathing and those kind of issues?
I am actually trying to work on some pamphlets to have for our patients. That way they can have different kind of emergency plans in that sense. I think unfortunately, the biggest thing is to try to have some way to have somebody advocating for you. Um, Knowing that you can say, this is my power of attorney, please talk to them, because you may not be able to speak for yourself is probably one of the most important things. Because if you feel very strongly about not wanting to have a breathing tube, I don't want the emergency room doing something that would be against your wishes. But overall, I think fortunately we're not running into that situation too much. So maybe I'm not giving you a full answer to what you're looking for, but Dr. Simmons, do you have anything to add?
Yeah, thanks. So, yeah, being in the emergency room with shortness of breath is a really frightening experience for anybody, and certainly for someone with ALS who may have other physical limitations as well, including, as Dr. Twomey said, communication limitations. So we do try to coach them to the extent possible in advance. And that's where Dr. Twomey has been working really closely with us in order to help people understand what to expect if that situation arises and how to advocate for themselves. If they end up in the emergency room, we do ask people to try, and we encourage them to try to have a plan in place before they get to the emergency room, and so that they can clearly communicate to the individuals there what they do or do not want. Because perhaps one of the most challenging situations for individuals with ALS is if they get taken to the emergency room because of a sudden episode of shortness of breath, and they haven't made decisions about whether they do or do not want to be on a long-term mechanical ventilator. The default way that emergency rooms operate is if people haven't made a decision, of course, they will be put on a ventilator in order to keep their breathing going. And so trying to work this out in advance and helping people understand what may be coming is really, really a key to good care.
Speaking of understanding what could be coming, when in a person's ALS journey with you, do they start having these conversations about breathing and speaking to the pulmonologist? Is it a lot of information up front? Do you recognize that on their first visit we want to talk to them, or maybe their second visit? How do you determine when Dr. Toomey is going to bring in, or maybe a different person to talk about respiratory therapy?
Yeah, so as we started to think about this, Dr. Toomey and I were chatting about this. We realized there's no standard playbook, that there really isn't sort of a best practices way to do this. So we're doing what we think are best practices. And so when we see anybody in our ALS multidisciplinary clinic, they always have a breathing test during that clinic, which means they'll blow into a machine and we'll get a number called the forced vital capacity, which tells us how much air they can blow out all at once, and a negative inspiratory pressure, which tells us how hard they can suck in terms of their respiratory strength. Based on those numbers, if they hit a certain level, we then refer the patient now automatically to Dr. Toomey. Our step used to be that we would simply prescribe a breathing device we call a non-invasive breathing device, a mask, and we would manage that with the respiratory therapist. But now we automatically make the referral to Dr. Toomey at that point, and that point for us is when the forced vital capacity is less than 50% of predicted, or when the person is clearly having symptoms of shortness of breath, or for people who might have a number greater than that, if they have other complicating medical factors, such as maybe emphysema or COPD from other lung issues, we would like her to be involved as soon as possible, because we know that will be unusually complex to manage. I'll let Dr. Toomey provide details if she wishes.
That's a great summary of it. Because I know I'm receiving everyone after you've met them for the first time. But yes, we typically are using our general criteria for when we know insurance will wind up offering to pay for these devices. But absolutely, I'm looking, if somebody's complaining about shortness of breath, I want to know them sooner. That way I can get them that device as fast as possible. And I'm looking for signs and symptoms possibly of hypoventilation, which means that you would be holding onto carbon dioxide, and things such as morning headaches. If you're falling asleep during the day and a few weeks ago you weren't doing that, and you can't explain it just because you had a bad night's sleep. Then the other aspects of the care too, such as how well are you managing your secretions? Are you having pneumonia over and over again? There's so many different parts of pulmonary care that we're looking at all of that to make sure that someone's staying healthy.
And Dr. Toomey, because you will be really focusing on the ALS patients and their pulmonology issues, their breathing issues, that means that instead of this extra step in the way where they might get a tool or go somewhere else, you will over time become more and more of an expert in understanding the issues unique to the ALS community, I assume. So it's not like just going to a pulmonologist or a respiratory therapist. It's really someone that specializes in these unique cases. So how do you see that making you a better expert at their care now and over the next 2 to 5 years?
It's been very eye-opening and amazing to me. I think the first thing I will say is that for the 30, 40 patients that I've already met so far, you get reminded every single day that everyone's unique, and this is personalized care. So I think that will be my driving force going forward is, continuing when I work with all the respiratory therapists who are going out to the homes and setting up patients with their ventilators that, this is not one size fits all. So it'll be keeping me on my toes for a really long time, but that's a great thing. And we're providing very compassionate care. And that's another part of this that I think is very important. I am hoping to be involved in Dr. Simmons' research very soon as well, because we have different things that we're looking to consider for initiating BiPAP in patients and then the ventilator support going down the road. So this will be something that's going to continue to grow and blossom, I think, over time, but I'm very excited for that.
Okay, Zachary Simmons. I didn't want to interrupt.
Oh, no. I was just going to say, Dr. Toomey mentioned the research, and I was wondering if that was something you'd like to hear briefly about, Tony.
I was actually going to ask about that because I assume that having a pulmonologist who's going to focus on ALS care means that you can collect a lot of data back from her that can improve your research about what makes a clinic great or about other potential research studies.
Yeah, thanks. Yeah, we've had. I really appreciate the opportunity to talk about this. This is very exciting, and this is really the other arm of our ALS clinic is the research program. So we've been involved in some collaborative research with the University of Pennsylvania, working with a pulmonologist there, Dr. Jason Akervo, and a neurologist there, Dr. Lauren Ellman, who have and Dr. Akervo, like Dr. Toomey, is a pulmonologist with a particular interest and expertise in ALS care. And so one study that we were involved in has involved looking at new ways to measure whether people are under breathing because of their ALS, and as a result of that, whether their carbon dioxide levels are rising. And we've been doing that using a skin monitor, what we call a transcutaneous CO2 monitor, to determine whether that might be a good or useful or even better way of monitoring people's respiratory status than some of the tools we have now, or at least an additional way of doing it. We're also in the process of setting up, and soon we'll be starting, another study that I'm very excited about, which asks the question, when in the person's course do you initiate non-invasive ventilation? Because the way we do it now at 50% of normal predicted forced vital capacity is not something that was done as a result of tremendous amounts of research. As Dr. Toomey mentioned, it's the level now at which Medicare and most insurers will pay for non-invasive ventilation, but the level was set based on people with other diseases and other observations rather than by true research in people with ALS. The question that we ask is, well, if you could start it earlier, would people do even better? Or would it not make a difference to start it earlier? So the study that will be coming up in the near future will look at whether starting non-invasive ventilation earlier has advantages over starting it at what we call standard time. Those are just two examples.
And I imagine that because you see a person with ALS every 3 months or maybe 6 months, and maybe longer because they could just be out of town. Something could happen where you don't get to see them within 6 months, that their forced vital capacity may be at 35% or 75%. I'm not the experts, you are. That's why you do your job and I do mine. But they might be at one level today, and it could be a very significant difference in 3 to 6 months. And if you know the trajectory of their breathing, you could have a better sense of, hey, let's not wait 3 months before you start talking with Dr. Toomey or you get this other tool.
Yeah, we did a study, and I'd love to hear Dr. Toomey's thoughts on this also, because this may be a way for us to also look at additional better ways to help people. But we did a study in the not too distant past where we allowed people to measure their own breathing capacities at home. They did home forced vital capacity measurements. And instead of doing them every 3 months, we had them doing them at much shorter intervals. And what we found is A, that you can get vital capacities at home that are high quality, and B, you can rely on them in order to determine when that person hits 50% of their vital capacity and therefore warrants non-invasive ventilation. And what we found is that by doing it more frequently, we did it at least monthly and in some people weekly. By doing it more frequently, you often will find that between visits, they hit that 50% number, and that's when you want to start your the non-invasive ventilation. Whereas if you had waited till they came to clinic, it might have been 2 months later and they might have been at 30%, or they might have shown up in the emergency room. And that's what we're really trying to prevent. So it's possible, depending on Dr. Toomey's thoughts on this and how we work together, that we might consider more frequent monitoring via home devices.
I'm not opposed to it. I
Mhm.
think that would be a great thing. I absolutely agree with everything you're saying as far as people have different trajectories. There are people where their breathing is not an issue for a while, and it could be 6 months later things are relatively similar and maybe only a mild decrease. But I know that I have, in the few months that I've been here already, there are patients that I've seen 2 and 3 times already
Mm.
because I'm worried about how they're doing, because that means now I'm basically seeing them every 6 weeks. So I have to use my clinical judgment to say, hey, I don't think it's safe for me to wait 3 months to see you again. And I'm not necessarily always doing a repeat test at this point because, Dr. Simmons has done the primary testing. They've fallen below that criteria where they weren't getting a device anyway. So now I'm fine tuning things. So we're talking about the home testing from the perspective of getting somebody to meet that criteria to get them on the vent faster. And I'm now kind of quarterbacking to get to use that vent to the best of its ability. But yes, I see how the trajectories change all the time for everyone. And I think if you could get more people to me sooner, that would be a very good thing at the end of the day.
Yeah. And it may be, as we work this out, that it may be that home testing isn't the answer. It may be that when I have some concerns, we just send the patient to Dr. Toomey directly, of course, which is what we're doing now anyhow. And then she determines what the best way to monitor these people is, because it's always better to see the physician and have an examination than simply to have the test done. So we were doing the home testing more frequently because we did not have a pulmonologist working with us. We'll see as we work closer and closer with a pulmonologist as part of our team, how much home testing is or isn't necessary.
And Dr. Toomey, I feel like I should have asked this from the start, because you are a pulmonologist and we're talking about breathing issues. What are some of the serious implications of having worsened breathing? Because it impacts your heart, your brain, everything if you're having this decreased breathing capacity, right?
Absolutely. I think the biggest thing that we're all concerned for on a day-to-day basis is that idea of pneumonia. So that's why we talk so much about airway clearance in addition to using the ventilator. But then just their quality of life too. If you can't breathe, you can't do much. So many of our patients do become wheelchair bound at some point, but still just to even be able to function, talk to someone, tell them what you need, having that ability to take a larger, deeper breath is so essential. So those are my main focuses, and as Dr. Simmons mentioned earlier, there is that ability to be able to reasonably extend life if we can get you to breathe better on a day-to-day basis.
Yeah, Dr. Simmons, what would be the impact if over time working with Dr. Toomey and your whole clinic, if you can see ways that you can improve breathing in general for people with ALS by some significant margin, what impact could that have on people with ALS and their caregivers, actually?
Yeah, so we always ask the question, how can we extend survival, and how can we do that by maintaining quality of life? And even though I'm very excited about a lot of the new medications that have either been approved or are under investigation because they do slow disease progression and extend survival, literally the single best tool we have for extending survival at this point is putting somebody on a non-invasive ventilatory device um, for a portion of their illness. It's really literally the single best way we have of extending life expectancy and improving quality of life, because Dr. Toomey mentioned earlier that when people start under breathing, they wake up with morning headaches, they have a disrupted night's sleep, they feel tired during the day. It really does have a negative impact. And so what we're hoping is that by improving the level of respiratory care that we provide, it will improve quality of life in many ways, that people will be more awake and have more energy during the day, that they will get a better night's sleep, that they won't wake up with morning headaches, that they'll be able to carry on a conversation without becoming short of breath so easily. I think there are many aspects of good respiratory and pulmonary care that will contribute to the person's overall general well-being, and those are very important pieces of what we hope to achieve.
Well, I really appreciate that. I've learned a lot, and I'm always learning about how the clinics can continue to improve. And that's partly because of our relationship between ALS United Mid Atlantic and our clinics here in Pennsylvania, New Jersey, and Delaware. Dr. Simmons and Dr. Toomey, before we end here today, is there anything you want to add about how you see the care at your clinic continuing to improve over the coming months and years? Let's go with Dr. Toomey first, and then we'll end with Dr. Simmons. So how do you see your role continuing to improve to help people with ALS?
So I'll just start off first by saying that I'm really excited to be meeting all the patients here who are at Hershey who are interested in working with a pulmonologist. I know that some of them already have some lung doctors at other sites because our patients are coming from all over the state. But I am here to help everybody who is willing to come see me. As we expand the opportunities here to work with pulmonary at Penn State, I love meeting people in person. That way we can work on titrating your ventilator in the office. We've had some really great success where someone will put their mask on in the office and I can make just small adjustments and I say, hey, does this feel better? And if you like it, we can go home and you can use something different at home. But also I do provide telehealth opportunities too for the people who are not able to come in. And I realize that that is an issue for many of the patients as well. And I look forward to continuing to be able to work with the neurology team. They have a great group of doctors and nurses who are really there for the patients in all the different ways, and to keep working with their home companies too, to really make a good network and have good relationships and rapport so that we can take care of these patients and make adjustments quickly, because we don't want to see patients ending up in the emergency room. So I think at the end of the day, these appointments are very worthwhile.
Thanks. So I'd like to thank Dr. Toomey for agreeing to be part of our group, and for me, it's this represents the natural evolution of the multidisciplinary clinic. Clearly having a dedicated pulmonologist in our clinic is at least on par with any of the other multidisciplinary team members that we have. None of us alone can care for all the needs of the people that we serve. And it's only by this kind of collaboration that we can offer people what, really best possible care. I was at a meeting where it was the NEALS, the Northeast ALS Consortium, and at this meeting, they had a special session on pulmonary medicine and respiratory support for people with ALS. And what I was really struck by was how well attended it was by neurologists and by other ALS professional caregivers, and what a high level of interest there was. And so I think we have finally reached the point where neurologists are saying, yeah, I really can't do this as well as some other people can, and this is a part of the care that should really be under the care of a true expert. So I'm excited about this and looking forward to continuing to provide best possible care.
Well, I appreciate that so much. And hearing from you shows that the interdisciplinary approach and the collaboration between us and our clinics and between the clinics themselves, because I know you all learn from the other professionals, not just at Penn State Health, Hershey Medical Center, but beyond that. It shows that we're not just making care better today, but we're launching ourselves to continue to improve that care, and it's making a big difference for those living with ALS and their caregivers. Because we can't stress enough that if you're following 250 people with ALS in a given year, you're really caring for over 500 people, because that's them and at least one person who's with them, and usually more, whether it's a spouse or loved one like a child or parent. So it's a whole network of people you're supporting with your expertise. If you want to learn more about Dr. Simmons and Dr. Twomey and the work at Penn State Health Hershey Medical Center, or at any of our 10 partnered clinics and centers, please visit us at www.alsmidatlantic.org, and you can find out about our care services, the research we fund, including at Penn State Health Hershey Medical Center, and get involved in some of our events. Dr. Simmons and Dr. Twomey, I really appreciate hearing from you, and I look forward to continuing this work because it's going to make a big difference in the lives of others.
Thank you so much.
Thank you, Tony.
And please continue to subscribe and follow us on all of our social media channels at YouTube and Spotify and iTunes. Leave your comments because it helps with visibility. And again, visit us at alsmidatlantic.org.